One of the more extreme claims made by Dr. Dewi Evans during the investigation of Lucy Letby was that there'd been an injection or administration of a noxious substance. We can see here that Dr. Evans made this comment with regard to child A, and indeed it was included in some of his earlier reports. We don't know for how many children it was mentioned, but it's clear that Dr. Evans had indeed cited a noxious substance because it was discussed in court. So I'll just read out this answer that Dr. Evans gave during the court case. This was the twins in the first cases I dealt with were presented in this way, and it's not a criticism. None of us knew what had happened. In other words, we just had no idea why these babies had collapsed. So what crossed my mind was obstruction in breathing, smothering. The other possibility which I mentioned, part of the differential diagnosis that that doctors do, is that he'd received an injection of some noxious substance. But I just mentioned that I have dismissed that. So what a lot of people don't know is that Dr. Evans did mention a noxious substance at another point in the court case. And here is the good old reliable BBC who made a headline out of this remark. So in this video, we're going to examine this incident and see what exactly was said, and also examine the significance of this. So this is the comment that was made in court, essentially. We see here, Dr. Evans said, the previously stable baby's sudden collapse begs the question whether child M received some noxious substance prior to his arrest or a bolus of air via his long line. So firstly, we're going to look at the court transcripts when Dr. Evans is asked about this noxious substance with regard to child A, or baby A as it's often expressed in the court case, or sometimes expressed. We're going to begin here. Now, initially, Dr. Evans, you offered a potential alternative cause of baby A's collapse and death. Can we just deal with that? First of all, what it was, and secondly, whether you still suggest that that is a possibility. So it'll probably become clear that this is Ben Myers cross-examining Dr. Evans. No, we've already read over this, but I'll read over again. No, right. This was the twins in the first cases I dealt with were presented in this way, and it's not a criticism. None of us knew what had happened. In other words, we just had no idea why these babies had collapsed. So what crossed my mind was obstruction in breathing, smothering. The other possibility which I mentioned, part of the differential diagnosis that that doctors do, is that he'd received an injection of some noxious substance, but I just mentioned that. I've dismissed that. I want you to remember this phrase, differential diagnosis, because we're going to examine that later in this video. You're not suggesting that, on the evidence as you now know it to be, that that's a creditable alternative. No, if somebody asked me, give me 5 or 6 reasons why this baby could have collapsed, it would have been one of the reasons, but no. I'm sorry, you finish your answer. No, I finished. Can I just deal with the term that you've used, because it's likely we're going to hear it again during the evidence, so I'm asking you to define a differential diagnosis. Yes. What is a differential diagnosis to a medic? Yes. If you have a patient, any patient, who presents with an illness, there may well be 3 or 4 reasons to explain this illness. Babies are physiologically fairly simple individuals. So in a baby who has collapsed, the differential diagnosis would include hypoxia, lack of oxygen, sepsis, infection, airway obstruction, again causing hypoxia. So notice, really, at some point, someone should go through everything that this guy has said in this court case and analyse all of it. That's an enormous task. I've only got through 3.5% of the closing statement of the prosecution. This court case is full of such abject nonsense and such specious rubbish that to actually deal with it all is just a phenomenally huge task. But I will get into everything that I possibly can as time goes by. But I'm not going to analyse everything that he says here. But again, he's saying babies are psychologically fairly simple individuals. Then he's mentioning all these things that he has supposedly ruled out, but there's very strong evidence that they were present. Anyway, let's continue. So we would go through a list. We've discussed tamponade, that's another. So therefore, there's a whole list of potential conditions that could compromise the stability of your baby. And that list of conditions is what we call a differential diagnosis. All right, so is it another way, in effect, of putting what Dr. Jerry was articulating in the witness box yesterday? He was going through possibilities. Yes. This is the method by which your profession, in effect, works in real time. Yes, it's thinking out loud. Finally, on baby A, please, Dr. Evans, the means by which air could have been inserted into a baby's circulation. From what you know of the way in which baby A was being treated, what are the possibilities? Well, there are only two, really. Sorry, there's only one, really. The air would have gone through an intravenous line, and that can only occur in two ways, accidentally or on purpose. So again, this is very significant, because he concluded that it always happened on purpose. He never eliminated, as he in other parts, in other videos I've mentioned, that he did diagnosis of exclusion. He never excluded the possibility that this had occurred accidentally, even though we heard from Dr. Hindmarsh, or is it Professor Hindmarsh, I should say, during the court case, and he found that air is accidentally present in infants with great regularity. Again, we can't dwell on this too much. We can't dwell on all the ridiculous statements that Dr. Evans has made in court and all of the flawed things that he's conveyed to the jury. Yes, so those are the only two explanations. Some time ago, I obtained a copy of all the intravenous bits and pieces of equipment used at the Chester Hospital, which we're all familiar with. We are all familiar with these lines from visiting people in hospital and intravenous bag line. I won't go through the whole bit, but doctors and nurses were so obsessive about ensuring that air does not get into the system. We're absolutely obsessive about it and always have been, and it's much better now than... So having rigged up the system that was used in Chester, and it's in a room in this court, in this building, so we could demonstrate it if necessary. I rigged it all up. There's no way air could have gotten into baby A by accident. The fail-safe systems, the monitoring, the alarm setups, which have been present for, a couple of decades, I suppose, ensures that this is not something that can occur accidentally. But as we know, Professor Hindmarsh did actual clinical research. He didn't just get a couple of items of equipment and then fiddle around with a bit and go, oh, there's no way that the air could possibly have gotten accidentally. He did actual clinical research, and he discovered that air does enter into the circulation of infants with significant regularity. It was present in I think it was 35 to 40% of the infants that he examined. So immediately, you can just throw that evidence out of court as being completely worthless. So, sorry, this is actually Mr. Johnson. I'd assumed that this was Ben Myers cross-examining Dr. Evans, considering he dropped several clangers, but apparently this is Nick Johnson cross-examining him. So Ben Myers is then asked to cross-examine Dr. Evans. This goes on for quite some time. I'm not going to go through all of that because there's I think 73 pages between the last mention of a noxious substance and this one that I'm going to go over now. We do learn that Dr. Evans wrote dozens of reports, but I'm not going to go over all of that detail. I'm just going to continue from here. Just looking at that report in 2017, the first one that you wrote, just at the end of it, paragraph 38, you suggest that one thing that might have happened here is that the person has received a noxious substance, such as potassium chloride. There's no basis for that whatsoever, is there? But you suggested it. Back to the principle of differential diagnosis, I've been asked by the police what on earth has happened with this baby, so therefore I gave them these ideas. This is quite a famous comment that has come out. I won't overanalyze that at this point in time. But I've already said that I've dismissed that, and so that's it. What do you mean giving ideas? Do you mean testing things out just to see if it works? No, differential diagnosis is part of clinical practice. What do you mean giving ideas, though? Differential diagnosis is a better way of expressing myself. There is no basis to suggest potassium chloride had been used, was there? None at all as far as I know. None at all as far as I know. This is why we have spent the last few hours talking about air embolism, which is what I did think occur. This is a very, very critical point. I want to nail this home, drive this home. There is no basis to suggest potassium chloride had been used, was there? None at all, as far as I know. That is why we've spent the few hours talking about air embolism. So I'll continue reading. You suggested both things in that first report. You suggested air embolus, and you also had a run at potassium chloride, didn't you? Of course I did, because you have to explore all potential causes. Now it's, Mr. Myers has spent a lot of time. Could it have been other conditions? And I have said no, and I've explained why. Fine, we are off to potassium chloride. I don't think potassium chloride was a factor here. I want you to remember all of this, because it's all going to be very important as we continue with the video. I'm not suggesting it is. I'm pointing out that it was something that you were ready to go with until it wasn't viable. I wasn't ready to go with it. I was presenting the police with differential diagnosis. This was a screening report. All the reports I prepared in 2017 were screening reports. I've been able to add to a number of them, I've changed my mind on a couple of them, and so on. So as far as these twins are concerned, air embolus is what caused baby A's death and baby B's collapse. We'll stop at this point, but I just want you to remember everything that you've just heard in this court transcript, because it's going to become very important as this video continues. So I'm just going to spend a little time here to go over what is meant by differential diagnosis. The phrase differential diagnosis refers to the process of distinguishing a particular disease or condition from others that present with similar clinical features. It's a systematic method used by healthcare providers to identify the cause of a patient's symptoms. It involves considering multiple possible conditions, then using medical history, physical exams, tests, and clinical judgment to narrow down the list. The goal is to rule out other potential causes and arrive at the most likely diagnosis. There's an example here of a patient coming in with chest pain, and the differential diagnosis including myocardial infarction, pulmonary embolism, pneumonia, gastroesophageal reflux disease, costochondritis, inflammation of the chest wall. The physician would consider factors such as risk history, ECG results, blood tests, imaging, etc. to rule out less likely causes and pinpoint the actual condition. In summary, differential diagnosis is the clinical reasoning process of figuring out what disease or condition is causing a patient's symptoms by comparing and eliminating similar possibilities. So there's a further explanation here where you see, first of all, there's a definition of what is meant by differential diagnosis, and then it states here, what does my healthcare provider's diagnostic process looks like? Asking questions, reviewing your medical history, performing a physical examination, creating a differential diagnosis, ordering additional tests, reviewing test results and symptoms, making a diagnosis. So it's very important to understand that this is all part of the process. I probably don't need to explain to you at this point that Dr. Evans hasn't done several of those points. And then there's this is kind of critical as well here. How does a differential diagnosis work? Your healthcare provider will try to learn as much about your symptoms as they can to make a diagnosis. The process begins during an exam when they'll ask questions related to your condition, including what are your symptoms, how long have you had those symptoms, what is the severity of your symptoms. Next, your healthcare provider will review your medical history to see if the symptoms connect to any previous health concerns or already diagnosed conditions. Questions about your medical history include, have you experienced these symptoms before? Have you noticed anything that might trigger your symptoms or make them worse or better? Have you experienced any major changes in your life? What medications, vitamins or supplements are you taking? Lastly, your healthcare provider will perform a physical examination by checking your blood pressure, heart rate and listening to your lungs. Your provider will compile a list of potential conditions that relate to your symptoms. To confirm your diagnosis, your provider might offer additional tests, etc., etc. So as this is for a living person, what a differential diagnosis relating to a person who had died might include would be looking at the pathology reports, looking at the coroner's reports, etc. All of the things that we know Dr. Evans has completely discarded. So I also wanted to just quickly go over what is meant by a screening report, because this is another term mentioned by Dr. Evans in court that he's claimed to have used. So a screening report plays an important supportive role in a differential diagnosis, but is not definitive on its own. Here's how it contributes. We've already covered a differential diagnosis, so I'll move on to the role of a screening report. Early identification. Screening tests are often the first step in identifying potential health issues in asymptomatic or at-risk individuals. A positive result may prompt further diagnostic workup. Narrowing the diagnostic field. If a screening test indicates a potential issue, e.g. elevated blood glucose or abnormal imaging, it can help rule in or rule out certain possibilities early in the diagnostic process. Risk stratification. It can highlight risk factors or preclinical indicators, e.g. high cholesterol in cardiovascular disease, that make certain diagnoses more likely, guiding next steps. Abnormal results on a screening report often dictate what confirmatory or diagnostic test should follow, e.g. a suspicious mammogram may lead to a biopsy. 5. Baseline data. Screening provides a baseline for monitoring progression or resolution, useful in both diagnosis and management. What a screening report cannot do, it cannot confirm a diagnosis, it's not specific enough for complex conditions, results may yield false positive negatives, requiring cautious interpretation. There's an example here, I don't think that we particularly need to go over that. Summary: a screening report helps guide, prioritise and refine the differential diagnosis, but must always be interpreted in context with clinical findings and other diagnostic tools. So I think based on that definition, there is no way that what Dr. Evans has done here that we went over in the court case can reasonably be described as a screening report. But we'll move on to other aspects of this so-called diagnosis as we continue. So essentially what should happen in a differential diagnosis is the following flow. This baby could have died for numerous reasons. I will review the notes. This evidence will enable me to establish a differential diagnosis. What certainly seems to have happened, I think it's generous to say that it seems to have happened, it appears crystal clear that this has happened, is that Dr. Evans has concluded this is inflicted harm. After all, he decided that within 10 minutes of walking to the police station. How would Lucy Letby have done it? Maybe she could have used potassium chloride. Now, a diagnostic process that works backwards from an assumption is rubbish. It is not a differential diagnosis. On no level is that a differential diagnosis. You shouldn't laugh really because it's very serious, but I mean it is laughable. It's not just that the scientific evidence that's been provided is bad. A major concern is that the diagnostic process has been completely misrepresented in court, and it essentially went unchallenged due to the absence of defence witnesses. Now, one of the ironic things about this is that some of the major flaws in the process that Dr. Evans has undertaken were not revealed when being cross-examined by Ben Myers. They were revealed when being cross-examined by the prosecution. So they're advocating. He's an advocate for the prosecution, even though he claims not to be. And they're using him to say, oh, look how great our evidence is. And then he's revealing all of the flaws with what he's done during the cross-examination from the prosecution. So in essence, in any form of differential diagnosis, there should be very clear symptoms. If there aren't symptoms, there's no need to investigate this any further. You don't rule something in and then rule it out when you realise that you can't make it fit and then use it in the court case anyway. So that's one of the critical things that I want you to remember. This was still used, this was still cited during the court case. It passed by very quickly, but that's very important because this was headline news. This was used in a headline by the BBC. This is something that Dr. Evans has stated in court, and that's going to become very important. Remember, he's decided in the case of child A, well, I'm going to rule that out completely. I've floated it as an idea as part of my quote-unquote differential diagnosis, and now I've just ruled it out because it doesn't fit in with any aspect of the clinical picture, presumably. But then he still used it in the case of child M. So it's very important for us to remember that as we continue in this video. So the next thing that I would like to discuss were comments made by the journalist David Rose, who wrote an article for Unheard that is very well known by now regarding the statistical aspects of the case. And he discussed this in an interview with, I think it was Talk TV, but it could have been GB News, one of those two stations. And he said the following things during that interview. Can I also draw your attention to the investigation that we published on Unheard at the weekend? Because what this shows is a major departure from the evidence that was heard at the trial. The prosecution claimed at the trial, largely on the basis of analysis by the prosecution expert Dewi Evans, that whenever a suspicious incident took place that either harmed a child or led to the child's death, Lucy Letby was on duty at the time where he deemed the suspicious incident took place. What I published in Unheard is evidence that when he first conducted an analysis and met the police over 2 days in October 2017, he identified 10 occasions when he thought suspicious occurrences had taken place, when in fact it then transpired that Lucy Letby was not on duty. At the trial, the prosecution presented a chart showing X's, a row of X's. She was on duty every time suspicious occurrences occurred. However, if you look at what we published in Unheard, you'll see there's a revised list based on Evans' initial analysis, which shows 10 gaps, 10 periods when he said harmful incidents occurred when she wasn't at the hospital. And some of these are set out in some detail. The deliberate removal of a tube, a catheter going into a child's navel, an attempt to smother a child with a hand placed over her face, while Lucy Letby wasn't on duty at those times. So, guess what? We never heard about those incidents during the trial. This is something that many of us will be familiar with by now, but it's important to actually think about what has been said here, that numerous supposedly suspicious incidents, were thought about. These include the deliberate removal of a tube, a catheter going to a child's navel, an attempt to smother a child with a hand placed over her face. And then Lucy, these are just taken out of the case. So they're going to be in the case and they're taken out of the case, essentially. And Dr. Evans has attempted to defend this by claiming that he revised his opinion due to new evidence. But the question would be, how did he actually come to the conclusion that these things were suspicious in the first place? You know, the deliberate removal of a tube, a catheter going into a child's navel. You can't just take that out of the case. You can't just say a catheter's got into a child's navel, whoops, now it's not suspicious anymore. There's new evidence. What? What new evidence? An attempt to smother a child with a hand placed over her face. So we never saw these allegations appear in the court case. We never saw Dr. Evans say that Lucy had attempted to do this. Actually, that would be a very easy way to murder a child. If you were on your own and had the opportunity, it's far more efficient than injecting air into a line via a small syringe. I haven't actually made the video yet in which I'm going to discuss some of the logistical aspects of the case and how they're probably impossible. But many nurses in particular have told me with a small 10 milliliter syringe, trying to get the amount of air in, it might be practically logistically impossible. Even if you had an infinite amount of time and no one else around, it still might not be possible to get enough air into the infant to achieve the effects that are alleged, even before you go into the scientific problems that we know about because of Dr. Shu Lee. But of course, there are people around. Most of the time, virtually all the time, there's loads of people around on these neonatal units. And Lucy Letby often isn't the designated nurse, so she's supposed to come in and inject air in a matter of seconds with a syringe without being cut out when there are other nurses on duty, when there are parents, etc., when she's not even a designated nurse. This is highly, highly unlikely from a logistical perspective. So a smothering, in a way, would actually make more sense. The problem is that it's not consistent with anything that's observed. So you can't put that in the court case. So here he's trying to put, Lucy must have smothered a child with a hand placed over her face, but then that's taken out because it turns out Lucy's not on duty. So how the hell did it go in and how the hell did it come out? The same as the noxious substance. And that's why I'm raising this point, because the noxious substance is still in the court case. It's still mentioned in court. Why? Why is it mentioned? There's no evidence for it. It's not the ultimate mechanism that Lucy Letby is charged with on that case. And elsewhere, Dr. Evans says, I realised that it couldn't be potassium chloride. Doesn't really give any indication as to why he thought that. But then he shouldn't be bringing it up in Child M because exactly the same applies. But we're going to go over this in more detail. But this is another indication of when he is speaking about differential diagnoses, it's total rubbish. It really is utter rubbish. So just to illustrate this, I want to go over this post from Reddit. This is a person that works in the NHS, so they're very qualified to give a view, and what they're saying here is entirely logical. So they begin by saying, this is really shocking. Evans is defending it by saying he revised his opinion due to new evidence, but how on earth was he reaching these conclusions in the first place? The process of forming a differential diagnosis follows a set pattern designed to capture all information required to gather a range of differential diagnoses and reduce them down to a final diagnosis. This process starts with very little information and a broad baseline of multiple differential diagnoses, then more information is gathered by an established range of methods that can be used to exclude the differential diagnoses that don't fit the clinical picture. For example, for those in the group who aren't medical, a patient presents in accident emergency with chest pain. Visual assessment upon meeting the patient, they appear in pain. Loads of differentials could account for this. Identify presenting complaint. Patient has epigastric pain. Okay, that could be a lot of things. Heart attack, gastric reflux, pancreatitis, gallstones, gastrointestinal cancer. Take a history of presenting complaint. Patient drinks 2 bottles of whiskey per week. Pain is radiating out to upper left side. Okay, this is starting to sound rather like pancreatitis, but he also has a history of high blood pressure and high cholesterol, so at this point we can't rule out heart attack. Take a familial history. There's no pancreatitis in his family, however his dad and uncle both died of heart attacks, so there may be a hereditary risk. Examination. Abdominal muscular guarding and bloating are pointing towards pancreatitis, whereas stethoscope examination of his heart doesn't find anything unusual. ordering tests and investigations, bloods ordered for both conditions, along with ECG to check heart rhythm, and an MRI to assess the pancreas. Once all tests are back, symptoms, examination, tests and investigations have ruled out a heart attack and diagnosed acute pancreatitis. This is how the process works, so I cannot for the life of me see how you end up with a diagnosis of baby smothering, line tampering, and then switch to something natural, because until you've ruled out everything natural, you cannot evidence something as unnatural as murder. Evans is claiming that he changed his mind due to new evidence. However, if he was missing any piece of evidence required for the diagnostic process, then he would have known about it and should not have been talking to the police about attempted murder before he had received that evidence and completed his diagnostic process. Also, this is a case where it is impossible to recreate all of the differential diagnosis stages. There is no longer a live patient to examine, nor a body that can undergo SE1 post. So let me just read that again. Nor a body that can undergo SE1 post-mortem. I'm not entirely sure what is meant by that. I might have to look that up in a second. So another thing I find very dubious about Evans' diagnosis is that he felt able to exclude all the possibilities until only attempted murder remained. As I've discussed this in previous videos with regard to his diagnosis of exclusion. As per my example, if the patient dies and it transpires no one had managed to order the bloods, the CT in history cannot prove beyond reasonable doubt that the patient dies of pancreatitis because he may have had pancreatitis but died of a heart attack, alcoholic being more at risk of them. Of course, the autopsy may be able to prove it because the pathologist can take an in-depth look at both organs, yet in this case zero regard had been given to the findings of the pathologist, whose job it was to examine the infants and look for evidence of both natural and unnatural death. This is why Horden said that some cases could not be explained and required forensic analysis, not because she lacked the assessment skills of Evans, but because she understood the limitations of a solo paperwork review exercise. The big mistake here had been to believe Evans' hype about himself. The whole thing is truly awful. So I think the SE post-mortem comment may be slightly mistyped, but the meaning of that comment is crystal clear. Then the same poster goes on to say the following. His idea of a differential diagnosis appears barking mad. If there was no evidence for the use of potassium, then why was it in the differential diagnosis in the first place? All differential diagnoses have their basis in evidence. If you are preparing a screening report, then you must have evidence to screen that would reduce the differentials down to a smaller number for which there exists some level of evidence. A diagnostic process that works back from, okay, if someone wanted to kill this baby, how would they have done it? Perhaps potassium is gibberish. The process followed should be this baby died, I shall review the notes and establish a differential diagnosis. The serious concern here is the misrepresentation of the diagnostic process that went unchallenged due to the absence of defence witnesses. If this goes to retrial, the defence need to get a medical witness to demonstrate that Dewi doesn't follow an appropriate process. That could be done by an academic who teaches clinical reasoning. I think it's very clear from what we see just with regard to this noxious substance that the processes followed by Dr. Evans are deeply inappropriate. I'm not going to comment further on why that is. You can draw your own conclusions from that. But the important thing to note is that there's no way that there's been an acceptable process followed to rule out a noxious substance in one case. That shouldn't even have been in the court case in the first place. That's just something that's pulled out of the air, pulled out of the ether, out of a hat almost. You know, you could have just put a load of conditions in a hat and just said, oh, maybe it's this, maybe it's that, maybe it's that. Oh, I've ruled that out now. But then you mention it with regard to Child M, even though there's absolutely no evidence for that. It's not what Lucy Letby was charged on, and as we'll see, it doesn't appear at any other time. It's just a throwaway remark that he just randomly throws into the court case at some point. And again, I'll leave people to conclude why he did that. So I just want to mention, previously I've discussed in another video that Dr. Evans has used this diagnosis of exclusion for embolism. So he was cross-examined on this by Ben Myers. Ben Myers established with him what is meant by diagnosis of exclusion. He's since tried to backpedal on that and suggest that his diagnosis was not entirely a diagnosis of exclusion when it clearly was. But to be fair, as I've said previously, and I'll say it again, and I don't see how anyone could possibly argue with this, nothing that appears in this court case can possibly be described as a diagnosis. It doesn't meet anything that would even come close to the medical standards required to describe it as a diagnosis. It's just a series of cobbled together theories and hypotheses that were required in order to attempt to make Lucy Letby look guilty, and, you know, credit to them, they've managed to do that, they've managed to put her in prison. In terms of its medical value and medical merit, it has absolutely none whatsoever. And Dr. Evans has contradicted himself so many times by now, he can't even answer questions to non-medics, let alone could he go up against a neonatologist. Even if he was to be interviewed by me, I would just destroy him. Like, it would be the end of him. If he was to come on camera with me for 3 hours and I was to ask him questions, by the end of it, he would just be absolutely finished. Let alone, imagine if you got a neonatologist to do it, or a medic. At least I've spoken to some and can, gleaned a lot of insight from them. But there's just no way that he can actually objectively answer questions at this point. That's why when he's made statements recently, he's made some kind of pathetic generic statement, because he can't give specific answers to specific questions anymore. It's as simple as that. So here's what he said about the noxious substance. And you can see the first two comments here. I'll read them out. They're on the screen now for people that can see the screen. The first two comments are related to child M, and the bottom comment is related to child A. So in relation to child A, he said, just to emphasise again, what crossed my mind was obstruction in breathing smothering. So we know, he's probably forgotten, that didn't only cross his mind, he wanted to cite that as part of the court case, but then Lucy wasn't on duty, so he couldn't throw it in there. The other possibility which I mentioned, part of the differential diagnosis that the doctors do, is that he'd received an injection of some noxious substance. But I just mentioned that, I've dismissed that. Have you dismissed it, Dr. Evans? Have you dismissed it? Because you also said, this begs the question whether child M received some noxious substance prior to his arrest. So let's just have those two statements side to side. It's difficult to read this properly because it's such an incoherent, babbling sentence, but I mentioned part of the differential diagnosis that that doctors do is that he'd received an injection of some noxious substance. So let's start from there. He'd received an injection of some noxious substance, but I just mentioned that, I've dismissed that. This begs the question whether child M received some noxious substance. So what is the difference between these two cases? In the case of child A, you dismiss this completely. In the case of child M, you're now just throwing it into the court case. What is the possible justification for that? I can answer that question very simply. There is no justification for it, but we're going to go into this in more depth. So next we're going to look at the Court of Appeal document. As you see here, baby M, attempted murder, mechanism, air embolus. There's only one mention of a noxious substance in the Court of Appeal judgment, which we're going to look at in a second. But it's very clear that the mechanism that was utilised, at least allegedly, was an air embolism. There's no mention of a noxious substance. The only mention of a noxious substance in the Court of Appeal document is here, where it notes that when Dr. Evans prepared his first report, the only other contender for the collapse was the administration of a noxious substance, but he accepted in his evidence that there was nothing to support that diagnosis. He was therefore left with air embolus as the explanation, yet another indication that this was a diagnosis of exclusion, except he hasn't excluded hundreds of things, as we've discussed in previous videos. But yeah, there's no. This is just an entirely frivolous remark that's been made in court with absolutely no foundation whatsoever, yet it's been dropped into the court case and generated headlines. To say that this is inappropriate for someone who's supposed to be an expert witness, who had probably forgotten that earlier in the court case he'd said, I ruled out that noxious substance was submitted and was administered in any way. He'd probably forgotten that he said that when he then later said, oh, there may have been a noxious substance or maybe it's air. So I have prepared a document here which took a bit of research and frankly is above my pay grade quite significantly. But it wasn't impossible for me to put this together, and it just shows the different presentation and symptoms that you have in infants with regard to potassium chloride poisoning versus embolism. Now, you could argue that Dr. Evans hadn't specified potassium chloride, but he did specify that with regard to child A, so he must have suspected the same noxious substance realistically. Although since he's making stuff up on the fly, he could claim it was a different substance, I suppose. But it's fair and reasonable to assume that he's referencing potassium chloride. So the main thing is the clinical presentation and vital signs for the two are completely different, as we'll go over here. Potassium chloride poisoning, severe hyperkalemia. Infants with acute casein overdose, potassium chloride, I'll try to read that potassium chloride. typically collapse due to overwhelming hyperkalemia. That's just the name of the condition of poisoning. Early signs may be subtle, but as serum potassium, K plus just means potassium, it's the chemical name for potassium, rises, there is progressive cardiac conduction disturbance. Patients may become weak or flaccid and often have nausea or vomiting if conscious. Rapid onset bradycardia, hypotension, and arrhythmias, heart block, ventricular fibrillation can occur. Importantly, ECG monitoring will reveal peaked T waves, prolonged PR interval, widening QRS, and loss of P waves as hyperkalemia worsens. Muscle tone and reflexes tend to be depressed, flaccid paralysis in severe hyperkalemia. In an infant, vital signs often show bradycardia and hypotension. Apnea may ensue. There are usually no cutaneous or respiratory signs specific to hyperkalemia, no skin rash, no respiratory crackles specifically. Now, I'm sure people are familiar with this immediately. I'm sure people know immediately that they are present in an air embolism. Air embolism. In infants, vascular air embolism, often iatrogenic, presents as a sudden catastrophic event. Common scenarios include air entering an IV or central line, or a tension pneumothorax air leak during mechanical ventilation. The presentation is very acute. An infant may suddenly become cyanotic, gasp or cry out, and then quickly lose consciousness. Cardiovascular collapse is typical, SpO2 plunges, blood pressure falls, and shock develops. Initially, there may be tachycardia and agitation from hypoxia, but this rapidly gives way to bradycardia and cardiac arrest as output drops. Unlike KCI poisoning, patients often show marked respiratory distress, gasping, decreased breath sound if tension develops, and sometimes a characteristic mill-wheel murmur or crackling sound can be heard over the chest from air in the heart, though this is rare in infants. Notably, in intubated patients, the end tidal CO2 precipitously falls due to blocked pulmonary flow. Skin may show sudden cyanosis or pallor. There can be mottling. In central air embolism, paradoxial to arterial side, there may be seizures or focal neurologic signs. In summary, hyperkalemia tends to present with progressive weakness, flaccidity, and primary cardiac arrhythmias with bradycardia, hypertension, and classic ECD changes, whereas air embolism presents with immediate respiratory distress, hypoxemia, and acute cardiovascular collapse, often with tachycardia, then rapid bradycardia, but no classic peaked TECG signature. A sudden drop in SpO2 and end tidal CO2 is a clue to massive air embolism. So even that in itself just indicates immediately that the clinical presentation for potassium chloride poisoning would be completely different to an air embolism. So you cannot say what Dr. Evans said in court, which is, oh, it's either a noxious substance or it's air. I'm not sure which one. But I'll never reference the noxious substance ever again. They have completely different clinical signs before we even look at anything else at all. But I do want to go through what I've prepared in full. So we'll move on to ECG and cardiac monitoring. KCI poisoning. The hallmark is hyperkalemic ECD changes. As potassium rises, ECG shows tall peaked T waves, progressive PR prolongation, QRS widening, often merging into a cine wave, flattening or loss of P waves, and eventual cine wave appearance or asystole. Ventricular tachyarrhythmias or heart block are common, and idioventricular rhythms or asystole can occur rapidly. In infants, these changes precipitate bradycardia and pulseless electrical activity. Air embolism. There is no pathognomic ECG pattern for air. ECG changes depend on the hemodynamic effect. Acute right ventricular strain may produce incomplete right bundle branch block or ST/T changes, or one might see non-specific ST segment elevations or depressions. More often, the monitor shows a sudden ventricular arrhythmia or bradycardia arrest without the gradual pattern seen in hyperkalemia. Importantly, monitors often show a sudden sharp fall in end tidal CO2 in intubated patients at the time of embolism, indicating a loss of pulmonary perfusion. Transesophageal echocardiography or precordial Doppler, if used, may visualize air bubbles but these are not routine in emergencies. Key contrast. An ECG with tall peaked T waves and widening QRS is highly suggestive of hyperkalemia KCI overdose. In contrast, an infant with sudden collapse from air embolism will not have the classic hyperkalemic ECG changes. Instead, the ECG may show an abrupt arrhythmia or just a downtrending CO2 oxygenation. So again, completely different clinical signs. So now we'll move on to imaging and diagnostic findings. Potassium chloride hyperkalemia. There are no specific radiologic findings of potassium overdose on plain films or CT. Diagnosis is clinical and biochemical. Serum potassium is extremely high, and other electrolytes labs will reflect acidosis or organ dysfunction. Point of care ultrasound may show poor cardiac contractility or ventricular standstill if the patient is in arrest, but no gas or structural lesion. Post-mortem, there are also no pathogenomic imaging findings. Forensic studies note that autopsy may reveal generalized congestion of organs and pulmonary edema. The blood may be hypertonic and poorly clotted due to electrolyte derangement. One forensic report found salt deposits crystals in myocardium or other tissues in feces injected with KCI, but this is not reported in infants or children in overdose cases. Laboratory analysis of post-mortem fluids is the main way to confirm KCI poisoning. Vitreous humour or blood will show extremely elevated potassium, far above expected post-mortem levels. Of course, we know no such laboratory analysis of post-mortem fluids took place. We know there wasn't any post-mortem work done by Dr. Evans whatsoever. He never examined the infants. He just came up with stuff off the top of his head in the police station, essentially. So let's move on to air embolism. Imaging can reveal air in the circulation. If the patient survives long enough for imaging, a chest X-ray may show radiolucent dark areas in the heart or great vessels, and a CT scan can directly visualize air bubbles in the right ventricle, pulmonary artery, or even in the arterial portal systems in paradoxical embolism. Doppler ultrasound TEE can be diagnostic. Air appears as moving hyperechoic dots in the heart. Post-mortem air embolism is often confirmed by imaging. Post-mortem CT will show extensive intravascular gas, often in both arterial and venous systems. For example, one forensic case of an infant who died on IV infusion showed air collections in both venous and arterial circulations, including the portal system. This is a key point. At autopsy, there may be frothy air in the heart chambers and great vessels. Importantly, because decomposition can also produce gas, forensic experts interpret patterns, large volumes of gas in unusual locations, e.g. coronary arteries, splenic or portal veins, strongly suggest antemortem air embolism. So this frothy blood in the heart chambers, the ventricles, I believe, is extremely important. This is a key sign of an air embolism, but we know, I will go over this when, among the countless other topics that I need to address, I make a video about the air embolism injection of air theory that Dr. Evans has put into this court case. There is a specific document in the Thirlwell inquiry which indicates that frothy air was not present, which it should be present if there's an air embolism. It's a fundamental characteristic. Of course, there's no frothy air if there's a noxious substance or if there's a potassium chloride poisoning. This is a very specific condition, distinct condition of an air embolism. Acute air embolism also does not produce distinct organ lesions like hyperkalemia does. Its hallmarks are the presence of gas in vascular structures on imaging or autopsy. So again, this is the way of recognizing potassium chloride poisoning or an air embolism if you're the medic or clinician that is seeking the signs. This isn't a clinical presentation of the infant. This is what you would gain by doing either a post-mortem or an examination while the infant is still alive. And as you can see, again, it's completely different. So you can't just group the two things in together. You just can't. So we'll move on to distinguishing features and some examples. ECG/T waves. A sudden collapse with classic hyperkalemic ECG, peak T wave, cine wave morphology would point strongly to KCI overdose. Conversely, if ECG is relatively normal, except for sudden arrhythmia or asystole, consider air. physical exam, hyperkalemia causes flaccid paralysis, areflexia. Air embolism often produces a distressed cyanotic infant with possibly a new heart murmur or crackles. Finding air in an IV line or tubing or seeing air bubbles with equipment is a direct clue to embolism. Post-mortem autopsy, intravascular gas is the hallmark of air embolism. Noxious gas is found in KCI poisoning. By contrast, a KCI fatality may show intense pulmonary edema and organ congestion, but these are non-specific. Toxicology can detect extremely elevated potassium post-mortem, especially in vitreous humour in KCI cases, whereas finding potassium is not meaningful in air embolism. Clinical scenario examples. An infant post-surgery receives IV fluids, minutes later it becomes cyanotic and arrests. CT or autopsy finds gas in the heart and lungs, consistent with massive air embolism. In another case, a baby accidentally receives a KCI bolus. Minutes later, ECG shows peak T waves and heart block, and the infant goes into asystole. Blood tests, if obtained, show potassium at a level of over 10, above 10 mmol per litre. The presence of classic ECG changes in hyperkalemia would differentiate the second scenario from the first, where the ECG likely lacked the peak T waves of hyperkalemia. These distinct features aid clinicians in distinguishing these two causes of acute infant collapse. And I'll just lastly show you that there are also completely different responses to treatment and context and timelines, but as these infants weren't treated for anything, that's not particularly relevant in this case. So I want people to remember that Dr. Evans has just lumped these two things in together in the court case quite explicitly. And you simply cannot do that because the clinical presentation is different. The effects that they have on an infant are completely different. If you're looking for signs that would indicate that one of the two conditions or one of the two mechanisms that occurred, they're completely different. The way that you establish this is completely different. Everything about receiving the noxious substance of potassium chloride and a bolus of air is completely different. If a proper differential diagnosis had been done, as we've already discussed, obviously clearly that wasn't done, that's crystal clear, but let's just say hypothetically this had actually happened, then you would eliminate one or the other by the clinical signs very easily, because the clinical signs are completely different, so therefore it cannot be, oh, it might be one, it might be other. It has to be one, or it has to be the other. So it doesn't beg the question of whether child M received some noxious substance, because if child M had received some noxious substance, all of the evidence he'd used to prove this, all the clinical signs, everything that occurred to the infant would be completely different to if he'd received a bolus of air via his lung line. So we can say categorically, either Dr. Evans doesn't know what he's talking about, that's quite possible, or he's introducing something in the court case here that is entirely spurious, that's entirely possible, or both of those things apply, and that's entirely possible. Finally, I just want to go over the sources of information in the previous section. So the first one is hyperkalemia in children, peer-reviewed by Dr. Tony Hazel, updated by Dr. Hayley Willicasey. I think it's authored by someone else, but I'm not sure the author is written at the top. But this goes into all of the effects or many of the effects that were discussed in the previous section. The next one is a paper that will probably be familiar to people, Vascular Air Embolism in Neonates, literature review by CoA Judgement and Dr. Shu Lee. This was also another source, Infant Death Due to Air Embolism from Peripheral Venous Infusion by Matthew Sal, Carrie Loveday, B.G. Brogdon and Cyril Vecht. When was this published? 2007. Arterial Air Emboli on Computed Tomography Autopsy by Olga Brook, Aviv Hirschenbaum, Aaron Taylor and Ahiva Enhel, probably that is pronounced, published in 2010, and Detection of Fatal Potassium Overdose, a case report review of the literature, a recent paper published in Switzerland in 2023, edited by Elvira Ventura Spagnolo, Gennaro Baldino, and Cristina Mondeo. So the next thing that I want to go through is a breakdown of what actually occurred in court for child M. Now, we can't go through absolutely everything, it would be ridiculous, and it would take far too long. So I've collated some of the highlights, and I'll make some comments on some of them. some of these issues that are important. But I want to be clear, above all else, that this indicates explicitly, beyond all doubt, that the so-called noxious substance never appeared again. So it was never cited as a possible cause of collapse in this infant at any stage during the court case. So I just wanted to go over the details just so that's crystal clear. So this is on the 12th of October 2022. Child M was born in good condition and was assessed as requiring special care. He had an unexpected life-threatening event at about 4 p.m. on April 9th. At the same time, his twin's blood sugar was dangerously low. The prosecution say he came close to death, but within 4 hours he was able to breathe unsupported in air. At 3:30 p.m, a fluid bag was attached to child M. At 3:45 p.m, he received intravenous antibiotics. The notes showed Letby was one of two to administer the medicine. Digital records show Letby's colleague was using the computer at 3:45 p.m. At 4 p.m, child M's monitor alarmed and Letby was first to the cot. The emergency was such that doctors were called urgently. So this, again, is a situation. Lucy's not even on duty. She's not even the assigned nurse for this infant. The monitor has gone off. She's done what she's supposed to do. She's gone to the cot, and there's an emergency, so she's called the doctors. Entirely reasonable behaviour. The consultant, Dr. Ravi Jairam, attended and noticed unusual patches of discoloration on child M's skin, which he thought were particularly noticeable because of child M's skin tone. He thought the patches unusual because normally, if a baby arrests and there is not enough oxygen moving around the body, the baby is uniformly pale grey or blue. What he saw, he thought similar to what he had seen during the resuscitations of children A and B. Of course, we now know that's completely wrong. Child M did not respond well to resuscitation. 6 doses of adrenaline followed in 25 minutes, and treatment was about to be withdrawn when child M suddenly improved. Dr. Jairam could not find any cause for sudden collapse, but the discoloration he saw caused him to suspect an air embolism. So Dr. Jairam couldn't find any cause because he's not a particularly great doctor, and he then suspected air embolism, but was completely unqualified to do so and cited evidence that is completely wrong. So let's just make that clear. At 9:14 p.m, Letby noted child M was tensing his limbs, curling fingers and toes, and rotating hands and feet inwards, signs of brain damage. So again, this is Lucy reporting on the signs of damage in this infant. She's just first to the scene, she's dealing with it, so obviously it's her fault this has happened. On the following night shift, child M had what the prosecution called a speedy recovery, although he did suffer further desaturations. Medical expert Dr. Dewi Evans said the rapid recovery would not have meant infection or a lung problem was likely. His conclusion was airway obstruction or embolus. So he's got airway obstruction as well. A paediatric neuroradiologist reviewed a brain scan in May 2016 and found brain damage for child M, likely caused by the cardiorespiratory collapse on the 9th of April. Mr. Johnson says when Letby's home was searched in 2018, a handwritten log of drugs administered during child M's collapse was found, and she had made a note of the collapse in her diary, long day twin resus. In police interview, Letby agreed she had connected a fluid bag to child M and had co-signed for medication at 3:45 p.m, but could not be sure if she administered it. As this is absolutely unrelated to any of the allegations, this is completely irrelevant. She thought she must have taken the notes home by accident and had simply noted what had happened in her diary. She denied that the notes were a souvenir and denied deliberately trying to harm child M. She could think of no reason how he would have suffered an air embolism. So in future videos, we're going to, hopefully I'm going to make one quite soon, on the ridiculous accusation that Lucy Letby took home a trophy or a souvenir with regard to child M, which is utterly ridiculous. The cross-examination on this is particularly embarrassing. The prosecution says the cases of child E to F and child L to M are similar in that one suffered an insulin overdose and the other an IV air embolism. Mr. Johnson, we suggest that coincidences like that simply do not happen innocently. Someone was responsible and the only credible candidate is Lucy. So let's count the problems with this. Firstly, Mr. Johnson has asserted, we suggest that coincidences like that simply do not happen instantly. Of course they do. They happen every day. That's a typical statistical argument that is bollocks. It's total rubbish. Of course coincidences happen, especially if you have a massive data set of I don't know how many hospitals there are in Britain, but clearly it's hundreds. It may be more than 1,000. I don't know the exact number. But you're looking at an enormous number of treatments across all of these hospitals. And in an enormous data set, coincidences absolutely do happen innocently all the time. Any statistician will tell you that. This is just another statistical argument being made by someone who has no qualification to make it and has said something that is just absolutely boneheaded, brain-dead rubbish, essentially. To say that someone is responsible is just unfounded. But again, this is another statistical argument. They're saying the only credible candidate is Lucy Letby because we know Lucy's always on duty because of that shift chart that we've addressed earlier in the video. So that's why he's saying that. So that's the second problem. The third problem is this idea about the cases of child E to F and child L to M being similar, in that one suffered an insulin overdose and the other an IV air embolism. So, I mean, this is just complete rubbish again. There's no link between these things whatsoever. It's total rubbish. It's just trying to link together twins in some way. And it's just absolutely without any scientific or medical merit whatsoever. So there's three pretty massive problems just with those few sentences. For child M, the defence say there is no obvious cause of collapse in this case, but it is not established that the obvious one is an air embolus. We are back in the territory of blaming Lucy Letby because there is no other cause. The mere fact she is there is being used as an explanation. Absolutely true. So we've reached the end of that day. We're going to move into 2023, but please note there's no mention of noxious substance. We're just talking about air embolism all the time. So we'll move on to 15th of February 2023. For the day shift on April 9th, 2016, Lucy Letby is a designated nurse for 2 babies in nursery 1. Mary Griffith is the designated nurse for child L and child M, who are the other 2 babies in room 1. 4 babies are in room 2, 3 in room 3, and 4 in room 4. There are 7 designated nurses for neonatal unit babies in total. Please note that we're dealing with, there's some overlap here between child L and child M because there were twins and the prosecution decided to try and link them together for reasons that I'll go into later. A handwritten entry for hypo screen results at noon, not attributed to a name, record results for child L. Child L blood sugar reading is 1.6 at noon, pre-feed. Letby co-signs a 10% dextrose infusion for child L around noon. Notes for child M record that designated nurse Mary Griffith took a break around 12:30 p.m. Letby is engaged in messaging people between 11:12 a.m. and 12:33 p.m. Letby messages Lisa Simpson shortly afterwards, "Oh good, hope you have a fab time. I'm in work doing an extra," and then just an X. Letby also messages her mother asking if her father was betting on the Grand National, and if so, to put a bet on grey horses for her. Her mother replies that it has already been done. The court hears Letby continues to be involved in messaging, including a group message to colleagues and friends. "Sorry guys, mad 4 busy days in work." Then invites the 3 people to crash at hers, apologising she hasn't fully unpacked yet. She adds, "Got Magnum, Prosecco and vodka, whoop, no disco ball, but sure we can manage." Child L's blood sugar reading is recorded as 2.0 at 2 p.m. and 1.5 at 3 p.m. I should say, I'll continue because there's more messages to come. Letby is a co-signer for the administration of medication at 3:35 p.m. Mary Griffith records a blood sample was taken from child L at this time, which was taken to the Royal Liverpool Teaching Hospital for analysis. The prosecution said the blood sample had a very high insulin level recorded and a low level of C-peptide. Child L was also given a bolus of dextrose, prescribed at 3:35 p.m. and administered at 3:40 p.m. Letby's mother messages at 5:28 p.m. telling her, "You've won, rule the world." Child L's blood sugar reading at 6 p.m. is 1.9. Letby responds to a colleague at 6:01 p.m. "Haha, why not? Work has been shite, but I've just won £135 on Grand National." She also sent a group message, "Unpackaging party sounds good to me with a flavoured vodka, just won the Grand National." Now again, would someone who is now about to attempt to murder a baby be sending these sort of jovial messages to people about having a party and celebrating a Grand National win and make sure you get my money on the Grand National? It's just not consistent with that at all. It's absolutely ridiculous. And I don't even know why this was read out in court, because this is read out in favour of the prosecution, but it weakens their case because it indicates that Lucy was not at all focused on, right, I've got to look for the right opportunity to murder someone. She was more concerned about what she was going to be doing after work and, you know, unpacking stuff at her house that she's just moved into, and so on. Anyway, we'll move on. The court is now hearing a statement from the mother of child L and child M, who had a routine pregnancy until a stage when she was not well. She recalls being surprised and shocked at being told she had to be admitted to hospital. She stayed there for 15 to 17 days and was asked if she was going to deliver naturally or via a caesarean section. Staff had looked through her file and were worried, so the decision was made for the birth to take place via C-section on the 8th of April. The babies weighing 3 pounds each looked very nice. The family were taken to the neonatal unit to see them in room 1 the following day, and the family were happy, and at that time it was not known what they were going to be called, deciding on the names a week later. Later, the mother was asked by a nurse named Yvonne to come down as soon as possible. She came down and saw child M had collapsed and chest compressions were underway. She was praying to see her, asking God to see them. Child L was okay on the other side of the room and Lucy Letby was present. She said her mind was totally blank and she just prayed. After what felt like hours, child M had stabilised. Each day the mother would come down daily to see the twins who had stabilised. 3 weeks later the mother was discharged and she continued to visit daily until the twin boys were also discharged. They hadn't put much weight on and were small, but otherwise healthy. Child M had no after effects for what happened to him. A statement from the father is now being read out. He said he was shocked and knew his wife needed to go to the hospital due to concerns over the pregnancy, and she stayed there for over 2 weeks before the C-section birth took place. The doctor said the babies looked very healthy before being taken to the neonatal unit by Lucy Letby and another nurse. He saw the twins a couple of hours later and they were both still fine. The following day the family visited. We were both proud parents and very happy. Within 10 minutes of being on the ward, the father rushed back to the neonatal unit where he saw a doctor doing chest compressions on child M. He said it was a very distressing image and one that still is in my mind. The staff said they didn't know what had happened to child M and child M had a heart attack. Child M later stabilised after about half an hour and there were no further issues with the twins in subsequent care. Child M had a brain scan with no damage recorded. The twins were only on the unit because they didn't weigh enough and it was a relief to get the boys home. So I just want to mention about the parents that really there is no basis for this being in the court case. I'm very sorry that the parents have been through a traumatic experience, but what they say has absolutely no relevance to the case and no evidential value at all. The only reason that it's in the court case is to try to emotionally sway the jury. It really serves no other purpose whatsoever. So I read it out here partly for that reason, also partly to indicate there's nothing here about noxious substance or any suggestion of noxious substance. We're now going to move on to the next day in the trial. So now we're on the 20th of February 2023. Notes show that at 16:02 on April 9th, child M collapsed and required full resuscitation. Medics administered 4 doses of adrenaline in just over 10 minutes in a bid to stabilise the infant. In all, child M required 9 doses of adrenaline and CPR for 29 minutes before he stabilised on a ventilator shortly after 16:30. And then we move on to 21st of February. Asked about the crash, this is Mary Griffin being asked. She recalls, child M's alarm went off, I looked over my shoulder, the lights were flashing. Lucy went over to see and said, yes, it's an event, it needs to be sorted. At that point, I stuck my head out round the door and asked for a resus call to be put out. Again, does that sound like Lucy trying to cause this collapse? Simon Driver prosecuting told the court the paper towel, along with the blood gas measurement report for child M, was discovered in a Morrison shopping bag beneath a bed in a bedroom at the defendant's former address in Westbourne Road, Cheshire, on July the 4th, 2018. I've just put that in because I will deal with that in a future video. Truly, that was a farcical, or should I say, yet another farcical part of the court case. So I'll move on to the 22nd of February. Nurse Belinda Williamson is first in the witness box today. She is giving evidence in relation to the collapse of child M on the 9th of April 2016. The prosecution say Miss Letby injected the infant with air, causing a near-fatal collapse. Miss Williamson is recalling child M's sudden collapse at 1600 on the 9th of April. She says he looked pale and mottled, not quite right, soon after a crash resus call went out and the infant needed 25 minutes of CPR and 6 doses of adrenaline. Jury are being read statements from other nurses that were present at the time of child M's collapse. This is agreed evidence. Nurse Ashley Hudson said she recalls Letby shouting, "Can I have some help, please?" She said there was no panic in her voice, which is normal to avoid alarming patients who may be on the unit. Does this sound like someone who's trying to murder someone? He said once circulation was restored and child M was stable, they vanished. Dr. Jairam tells the court they observed similar blotches in another baby in the case. They later prompted him to begin researching air embolus, the injection of air, as a potential cause. I think it's generous to describe what he did as research. And then 1146, Jerram tells the court, in June 2016, after a number of further unusual, unexpected and inexplicable events on the neonatal unit, the whole consultant body sat down and thought, we have to work out what's going on here. One of the things that came up in discussion was, could this be air embolus? I can't remember who suggested it. It prompted me to do a literature search. I remember sitting on my sofa at home with my iPad researching. I remember the physical chill that went down my spine when I read that, because it fitted with what we were seeing. I'll just mention at this point that elsewhere Dr. Evans claimed that he was the first person to ever mention this, so we can put that to bed immediately. So then, this is Ben Myers stating, details of decolorization doesn't appear in notes or statements because it's not what you saw, is it? Dr. Jerram again rejected the assertion. Mr. Myers went on to claim that Miss Letby had been a focus of interest for Dr. Jerram since the death of another child in this case, child D, in June 2015. He told the court another senior medic, Dr. Stephen Berry, had flagged to Dr. Jerram that Miss Letby had been working when a number of infants had collapsed or died in that month. All eyes were on Miss Letby then, Mr. Myers said. Clearly, yes, Dr. Jerram said. Mr. Myers said in that case there is absolutely no way he would have failed to record the blotches on child M. Dr. Jerram again explained, I recorded what I felt was relevant. And then we move on to the 23rd of February. Dr. Gibbs examined child M on the morning of 10th of April. He said he queried whether infection sepsis was the cause of the boy's cardiorespiratory collapse the previous day. It transpired he didn't have either of those, so there was no proper explanation, Dr. Gibbs said. Dr. Evans said from his review of the medical notes, he concluded that child M's collapse was completely unexpected. Dr. Evans said, this begs the question whether child M received some noxious substance prior to his arrest or a bolus of air via his long line. Dr. Evans said he ruled out infections such as pneumonia as the cause of child M's collapse, as he would not have made such a prompt respiratory recovery in the hours after. So we're just going to move on briefly to look at other instances of pneumonia on this neonatal unit. So Dr. Evans has just ruled out pneumonia, but he also ruled out pneumonia when, in the case of child D, when it was listed by the pathology reports as the cause of death, and then he just changed that to embolism. This is on the screen now with regard to child D. And then there's another child in the case that was ruled out of the court case because this child had congenital pneumonia with inflammatory response syndrome. But Dr. Evans decided that that infant doesn't need to be in the court case. Was this similar to what we mentioned earlier in the case where, in this video, where several conditions were ruled out the court case because Lucy Letby wasn't on duty? So we will now return to this document. Mr. Myers puts it to Dr. Evans that child M's collapse could have been due to some residual underlying issue. He disagrees and repeats his belief that air was injected, a claim Mr. Myers says he has no supporting evidence whatsoever for. Mr. Myers is now questioning Dr. Bohin. He puts it to her there is not much to support her conclusions. She says that the infant suffered a cardiac arrest, something caused that, the baby almost died. For me, air embolus fitted with that. So I don't want to go into the peer review of this case in too much depth because I've discussed it previously and I'll be discussing it again in the next video posted on this channel. I'll simply say that if Dr. Bohin had assessed this case blind, as I believe she should have done, for me there's absolutely no chance whatsoever that she would ever have come up with the idea that air embolism was to blame for any of the observed phenomena associated with this unit, just as a panel of now 26 medical experts have assessed the cases in the, independently and have concluded there's no evidence for embolism whatsoever. I don't think any neonatologist in the country would actually draw this conclusion if they were assessing the cases blind. Dr. Bowen never did that. Her conclusions were passed to her, and she here says, oh yeah, for me, embolus fitted with what I could see. Absolute crap, if you ask me, but she'll have to defend that at some point in court again. So moving on, Letby says as well as herself and Mary Griffith being the two designated nurses in that day, there were other nurses coming and going in room 1, along with parents present throughout the day. Letby, asked again by Mr. Myers, denies doing anything to affect child L's insulin levels. She agrees that child L's blood sugar levels remained low and cannot explain why that was the case. Letby says another nurse and Dr. Ravi Jairam came to assist child M. She says she cannot recall any observation or discussion of discoloration on child M's skin. Letby says she left later than 8 p.m. that night and she had a lot of documentation to file at the end of her shift. A nursing note for child M by Letby is recorded as being written between 9:14 p.m. and 9:22 p.m. on April the 9th. Letby said this was after attending to the clinical needs of child M. Letby said she would write contemporaneous notes on the back of handover sheets or on paper towels to keep track during the day. Again, we'll return to that in a future video. The court has shown a few notes written on paper towels which were recovered from the Morrison's bag at Letby's home by police. There are also medical notes on sheets of paper. They feature notes in the resuscitation of child M. Letby says the notes were kept in the pocket of her uniform and came home in her uniform. She says she did not have any other use for them. Also among the notes is a blood gas printout for child M. Asked to explain that note, Letby said she put it in her pocket and taken it home. Asked by Mr. Myers why she hadn't binned it, that is an error on my part. She denies having any use for the notes. So I'll be getting into that in a lot more depth in the future, in a future video. This was just an extraordinary part of the court case, frankly. But the other thing I wanted to address at this point is this thing of the twins being lumped in together, despite the fact they've got completely different conditions, and it really isn't relevant to consider them together. But this is again about creating an indelible emotional link between the two, so they can drag the parents on and get them to talk about their twins and all the rest of it. We never hear any contextual information about twins and about the problems that can be associated with them, etc., etc. It's just the emotional stuff of, we had twins and then this one struggled and then that one struggled, etc., etc. None of which has any medical or evidential merit, but it's simply used as a strategy by the prosecution to sway the jury. It's not. It's pretty transparently the case. So I just wanted to mention that briefly at this point. So I'll move on to the final little comment. This is just the prosecutor, Nick Johnson, confirming the only two staff members on duty for both days when child F and child L were poisoned with insulin were Lucy and Belinda Williamson. A staffing rota for the April the 9th day shift is shown to the court. Child L and child M are in room 1 with designated nurse Mary Griffith. Letby is designated nurse for 2 other babies in room 1. Belinda Williamson is the designated nurse for 3 babies in room 3. 4 babies are in room 2 and 4 babies are in room 4. So, a couple of things to state about that. Firstly, Lucy, again, is not the designated nurse for this infant. And then secondly, again, they are relying on the fact Lucy was always on duty. Lucy was there for all the cases. That there's no proof here whatsoever, even if you ignore the cruddy medical evidence, there's no proof here whatsoever that this wasn't Belinda Williamson or Mary Griffith. This could have been Mary Griffith and Belinda Williamson that supposedly administered this insulin, supposedly were involved in the attack of child M. Of course they weren't, because there were no crimes on this unit, but it relies, again, on this coincidence theory, on the chart, on the completely discredited, completely flawed statistical case that's been put forward. So in conclusion, there's 2 things that I just want to note at the end of this section. Firstly, every strand of this prosecution case is bullshit. There's nothing of any solidity underpinning any of it. Every time you examine anything that occurred in court, you automatically find numerous problems and fundamental inaccuracies. I should add to that, even when it's stuff being cited by the prosecution in favour of the prosecution case. Like, they cross-examined Dr. Evans to try and extract information from him that will support their case, and we now know that it's all nonsense, or that there's massive problems with it. The second thing I want to point out is there is no mention at any stage during the whole court case related to the portion related to child M of a noxious substance. It was just thrown in there for a second, and then it was never referenced ever again. So I wanted to make that crystal clear to you, so you just know, it wasn't returned to a later date, there wasn't any further questions about it, Dr. Evans never mentioned it again, he just threw it in there for a second, even though we've seen the clinical presentation that's involved with both, and it can't possibly be both of them, but he still just chucked it in there anyway. That's who he is as an expert witness. So we're now going to go over the panel summary for child M, or baby 13 as they termed this infant. So this was an infant that had severe intrauterine growth restriction delivered by elective cesarean section for oligohydramnios and intrauterine growth restriction of the first twin. As we mentioned earlier in this video, it was a problematic pregnancy and gestation for the mother. He was born at breech and bagged at birth for being slow to pink. He was plethoric, jaundiced, hypoglycemic, and was treated for possible sepsis with antibiotics and phototherapy. His white cell count and CRP were not raised. At 12-15 hours the next day, he developed fever, which subsided with change in environmental temperature, increased work of breathing, distended abdomen, and bile-stained nasogastric aspirates. The nurse was concerned enough to call the registrar, who stopped feeds and put the nasogastric tube to free drainage. 4 hours later, baby 13 developed apnea with desaturation and low heart rate. He was resuscitated, given cardiac massage, adrenaline times 6 doses, bicarbonate times 2 doses, saline times 2 doses, intubated and ventilated. Strangely, 2 doses of adrenaline were given before his airway was secured. He stabilised and was extubated the next day. A eustachian valve was detected on cardiac echo. He improved and was discharged at a month of age. So again here, the conviction, it was alleged that air was injected into the intravenous system, causing air embolism and collapse. So the panel hasn't even considered a noxious substance for this infant, just to make that crystal clear again. Panel opinion. Baby 13 had signs of possible sepsis from birth, including jaundice, requiring phototherapy and hypoglycemia, and was treated with antibiotics. So the problem you have throughout this court case is that we see Dr. Evans and we see doctors on the unit failing to acknowledge and failing to understand and failing to recognise the signs of infection. This is why this unit has been downgraded. It's been downgraded now for 9 years, and who knows if it'll ever be upgraded back to a level 2 unit. The next day, he clinically deteriorated for 4 hours prior to collapse, with abdominal distension, increased work of breathing, raised temperature, and bile-stained NG aspirates, and which were of concern to the nurse and registrar. The acute episode of desaturation and bradycardia was likely triggered by apnea from sepsis, abdominal distension with ileus, and prematurity. It could be also due to the cardiac eustachian valve, which can cause episodes of desaturation and bradycardia due to intermittent right-to-left shunting of blood through the foramen ovale. The resuscitation was chaotic, with adrenaline times 2 doses given before the airway was secured. Air embolism is sudden and catastrophic and does not present over 4 hours with gradual deterioration. So this is a point that we've already come up in this video. If you remember from the clinical presentation of air embolism compared to potassium chloride poisoning, it was emphasised very strongly that there is this rapid, sudden, catastrophic deterioration. It does not occur over 4 hours, and then the infant obviously recovers very quickly. So Dr. Evans made all kinds of comments related to the deterioration, failure to resuscitate, recovery of the infant, etc., etc. Many of these comments, most of these comments, possibly all of these comments are just simply plain wrong. For this infant, virtually everything that he said is just scientifically and medically incorrect. Patchy skin discolorations are caused by dilation and contraction of small blood vessels in the skin in response to hypoxia, which can occur in many conditions and are not diagnostic of air embolism. Non-specific localised patchy skin discolorations have not been reported in infants with venous air embolism, including IV air injection, and only Lee's sign and Liebermeister's sign are diagnostic of air embolism. If air was deliberately infused through a central venous line to cause air embolism, the line will have to be reinfused with fluid to prevent detection. Collapse from air embolism occurs instantaneously. It is doubtful this can be achieved quickly enough before other staff in the unit respond to the collapse. Conclusions: baby 13's desaturation and bradycardia was caused by apnea from sepsis or the eustachian valve. The resuscitation was suboptimal. So let's move on once more, having absorbed all that information, to what Dr. Evans said. So let me emphasise one final time that this was just thrown into the court case and then we never heard about it ever again. But you simply cannot place those two things side by side. That has been established beyond any doubt in this video, and it would be bad under any circumstances, but given that Dr. Evans has supposedly dismissed that for another infant, that would beg the question why he hasn't dismissed it for this infant, child M, when we know that if it was possible for it to be a noxious substance such as potassium chloride, there would have to be a clinical presentation that was consistent with that, and there cannot be a clinical presentation that is both consistent with that and the bowel severe various long line. It is simply, literally impossible. So I'd like to finish this video by looking at this article by the Criminal Bar Association of England and Wales, because this was pointed out to me the other day. It's a very recently published article, and they're talking about problems with the criminal justice system and issues with miscarriages of justice. So here they highlight two critical things in the Lucy Letby case. And I'll deal with expert witnesses second because I want to finish with that. But let's look at forensic science. This is something that I've mentioned in a previous video related to the insulin cases. In 2012, the Forensic Science Service was closed and work was then divided between commercial providers and police laboratories. The Parliamentary Group on Miscarriages of Justice has outlined that reckless policy decisions have brought forensic science to a point of crisis. Forensic science is not working for anyone, the courts, the barristers, and in particular for the members of the public who are caught up in the criminal justice system. The role of police laboratories has increased, and inadequate funding for defence experts leads to increasing risks of miscarriages of justice. Another major concern is the loss of DNA samples, CCTV footage, weapons, drugs, and mobile phone data. In the period between October 2020 and September 2025, 30,552 prosecution cases, the equivalent of 2% of all prosecutions, were dropped due to missing evidence. That's pretty extraordinary, is it not? This included 70 homicides and 554 sexual offences. The Metropolitan Police had 4.6% of cases dropped due to missing evidence. Further difficulties arise when people seek to appeal their convictions when vital scientific evidence has been lost or not retained. The development of digital forensics has outpaced the necessary infrastructure to investigate the offences. In addition, a lack of proper investment has caused severe delays in provision of telephone data reports. There was a national backlog in 2022 of over 25,000 devices. There are far too few trained digital practitioners in the police forensic units. Vital evidence which might undermine the prosecution case does not arrive in time for a trial. There is a plain inequality because the defence received digital evidence far too late to adequately examine, analyse and challenge it. Of course, this is a massive problem in Lucy's case. But this just underlines the problems in forensic science that have plagued this case, that have plagued other cases, and that will continue to plague the criminal justice system in the future due to this decision about the closure of the Forensic Science Service. I also wanted to talk about expert witnesses that is mentioned earlier in the article, so I'll just zoom in on this. It's becoming increasingly difficult to instruct an expert on behalf of the defence in a criminal trial. There are fewer professionals with expertise who are willing to provide reports for the fees that the legal aid agency will pay. Fees are much higher in the family court. In addition, experts are walking away from the criminal justice system due to a lack of certainty as to when they will give evidence during a trial. The prosecution has its own budget and can therefore afford to pay more than the defence. In child homicide cases and other areas where there are a limited number of expert witnesses, it is proving impossible in some cases to instruct any expert within the UK who is able to consider and challenge the prosecution evidence. Where experts are only willing to be instructed by the prosecution, it is a growing concern that their evidence, whether consciously or subconsciously, fails to be impartial. We are all aware of appeals against conviction based on errors in expert evidence. So, of course, this is hugely relevant to the Lucy Letby case, and if only there had been the kind of calibre of expert witnesses that we have available now, who were available in court, this egregious miscarriage of justice may never have happened. The other problems, of course, with expert witnesses that are not mentioned so much here are the quality of expert witnesses that are actually made available to the prosecution. It is clear in this case that the primary expert prosecution witness, Dr. Dewi Evans, is absolutely nowhere near the standard required. That's before you even look at the extremely dubious things that he's done in this court case, not to mention several other court cases previously. So when we see him in this case, introducing a noxious substance, having previously stated that he's eliminated it, but then it makes absolutely no sense for him to do so, but then he never references it ever again. This is exactly the kind of thing that we should expect from Evans, and it's no surprising when the system for expert witnesses, in common with the system for forensic science, is in such a dismal state to begin with. So I'm going to finish by summarising this video. Dr. Dewi Evans included the administration of a noxious substance in some reports submitted to Cheshire Police by his own admission. When questioned on this in court, Dr. Evans indicated that he had changed his opinion on this and has since eliminated potassium chloride poisoning as a possible cause of issues with child A. However, when speaking in court on child M, Dr. Evans dropped in a reference to a noxious substance, even though he had previously ruled this out with child A. No details were given, and this didn't form part of the prosecution case, as the mechanism of collapse for child M was air embolism, as listed in the Court of Appeal judgment. Similarly, no details were given regarding how Dr. Evans had ruled in a noxious substance for child M, but ruled this out for child A. It is clear that the presentation related to potassium chloride would be significantly different to an air embolism, so it is very hard to see how they could both be a possible explanation in parallel. Dr. Evans made some claims about having conducted a differential diagnosis in court, but these do not stand up to any scrutiny. The reference to a noxious substance was dramatic enough to generate media headlines, but was never referenced again in the court case, let alone was it examined during the trial or any meaningful mechanism proposed. This was something that Dr. Evans simply tossed randomly into the court case at some point, without ever relying on it for his hypotheses or theories, without it being cited as mechanism in relation to any of the infants in the case, and without explaining how he was able to include this in relation to child M, but never for any other infant in the case. It is not unreasonable to ask why Dr. Evans did this, considering that this throwaway remark has no scientific or evidential basis. One possible conclusion is that Dr. Evans was willing to say almost anything to secure a conviction, even if his comments were unsupported or completely baseless. So I think that deals with the noxious substance issue very thoroughly. This is something that many people don't even know happened. And that's an entirely reasonable thing, even for people that studied the case in great depth, because it's not an allegation that was actually tested in court. The fact that it was mentioned and then it generated headlines, of course, the dutiful BBC reported it because it made Lucy Letby look bad. But it should never have been reported, but more than that, it should never have been in the court case in the first place. But the fact that it's not merely the fact that Dr. Evans mentioned this notion of a noxious substance after he'd said, well, I've ruled it out. That's pretty bad in itself, obviously. But the fact that he places these two things alongside each other when they have a completely different clinical signature is just unbelievable. It tells you what... Well, I was going to use a word to describe him there. I won't use that word because I've resolved to be as fair as I possibly can. I fully believed the word I was about to use, but I won't use that word. I will leave you here. I'll leave viewers to insert their own word to describe Dr. Evans, but I couldn't possibly say much about it that was complimentary based on the things that I've seen him do in this court case. Finally, I'm recording this video on the day that Colin has lost his appeal. Now, I know quite a bit about this case. I don't think I'm going to make a standalone video on it because my channel's about Lucy Letby and it's not going to be a particularly enjoyable subject. I might do it in the future because I could go through the whole Court of Appeal verdict, but this channel really is dedicated to Lucy's case, and that would be an enormous amount of work for something where, unfortunately, the only way this guy's going to come out of prison for another 10 years would be if Lucy's case opens the floodgates somehow. Otherwise, he's been in prison for 17 years. It's taken him, I think, 14 years to get this appeal heard, 10 years to get to the CCRC, then 4 years for them to hear the appeal, and then they've rejected it. So he's only on a 30-year minimum sentence. I don't know enough about the legal system to know whether he gets out after 30 years or whether he's just on parole. As far as I understand, he's just on parole. It's not even inevitable he'll get out. But, you know, some simple maths would tell you if it took 14 years last time and it takes 14 years again, then he's going to serve his whole sentence and he's going to be seeking parole rather than appeal. So I don't want to invest too much time into this because, unfortunately, even though I've met some of the main people from this case, and I've met people that know this case inside out, including some experts, and they've spent several hours explaining to me why it's extremely likely, overwhelmingly likely, that Colin Norris is innocent. Unfortunately, he's lost his appeal, he's going to stay in prison. What I will tell people is that the defence has made what I would consider to be some unseemly blunders in defending him for this court case, and that is essentially why he has lost. When I heard about the strategy that the defence had used, I immediately knew that he was going to lose. Like, I was 99.9% certain I would have put my life savings on it, frankly. He just had absolutely no chance. So that's the first thing to know. And the second thing is, this case is completely different from Lucy's case for numerous reasons. The quality, for example, in this case, there were a lot less defence experts than prosecution experts. In Lucy's case, there are going to be much higher level defence experts than prosecution experts. There are numerous other details related to the insulin, related to the circumstantial case surrounding that, and various other details. But although it's disappointing, it's depressing from a human point of view, it's tragic, we shouldn't be too discouraged by this outcome, because the defence has really let this guy down badly, unfortunately. That's just my opinion, of course. But essentially, they accepted the insulin readings, and they accepted that one of the women that he'd been convicted of murdering had indeed been murdered. And they tried to argue that it couldn't be proven that Colin had done this. I mean, frankly, I can't see a snowball in hell's chance that that's going to get someone out of prison, given how difficult it is to get someone out of prison. As far as I'm concerned, they might as well not even submit the appeal in the first place. But I just wanted to scroll down to read a few comments here. This is the reference. The lady's called Ethel Hall, very sadly passed away. But essentially, the defence just accepted that she'd been poisoned. Once they'd accepted that, I don't even know why they bothered to go through the 14-year process. They might as well not have bothered, frankly. But I just wanted to read this bit at the end. I'm not sure if this is relevant. No, it's not. It's not relevant. Some campaigners for the nurse, Lucy Letby, who was serving a life sentence for the murder of 7 babies in her nursing care, had sought to link her case with Campbell's, arguing that in both the prosecution had relied on anecdote. Letby's conviction is being considered by the CCRC after 2 failed attempts to appeal. Her lawyers and a range of experts argue that poor medical care and natural causes, rather than deliberate harm, were behind the baby's dying at the County of Chester Hospital's neonatal unit. I should say that that's not the only link. There are other parallels between the 2 cases. However, I'll just continue reading. In its ruling on Campbell, the Court of Appeals sought to draw some distance between the 2 cases. They said, some observers have made clear in their applications to follow the proceedings by remote link that they seek to draw parallels between this case and other similar cases that may be ongoing. We make clear that we have each contributed to writing this judgment, mindful of the necessity to explain the decision we reach, which has been dependent upon our view of an intricate debate between eminent scientists, by identifying the relevant issues and addressing them in terms of an appeal against conviction in the circumstances of this case. And Mark MacDonald has made a response to this. The Court of Appeal rightly state their judgment with a warning not to draw any parallels with the Norris appeal and any others' cases. This appeal was decided on its specific facts and is profoundly different from Lucy Letby. Lucy now has 26 internationally renowned experts that all say no crime was committed and she's been wrongfully convicted. This, combined with fresh evidence that the jury did not hear, totally undermines the safety of her convictions. So I just wanted to add that so that people understand these cases are very different. I don't think that Lucy's defence is going to let her down. It's much stronger. It's much stronger in terms of having endocrinologists and biochemical experts. The panel is way stronger. We've got other assets. The circumstantial case is very weak and it's been debunked. Of course, we've got Dr. Evans. That's a big asset to the defence now. There's 11 items of fresh evidence in this case. This is not a forewarning of what will happen in Lucy's case. We've still got a lot of work to do to make this as big as we can publicly, and that's why I've written a book. That is the sole reason. I don't need to become a public figure and put myself in the media spotlight and everything that will entail. I'm just doing it because I can, and morally and ethically, I felt that I had to do it. And the aim is to make the book as big as possible, which, allied to documentaries that are going to be made, that are being made, will bring this in, hopefully more and more into the public eye. The aim is to make this as big as possible so that the general public, the average person commenting knows that this is an extremely unsafe conviction and is familiar with the details. The only way to do that is to get this on TV, is to try to write a viral book, which is what I've done. And that will be another advantage that we have in this case. This was all done very quietly in the background. We need to put the public pressure on the system so that the system knows they are being watched closely. They didn't feel that in this case. So they need to know there's public pressure. They need to know there's an overwhelming public feeling. So I've cited this comment by Paddy Hill of the Birmingham Six previously, where he said that the convictions weren't overturned because of the courts or the government, it was because of public outcry. There has to be that public outcry. It's always required in any miscarriage of justice case, otherwise it goes on for years and then decades and then many decades. We've seen with Peter Sullivan recently, 38 years, and then he's exonerated, completely innocent, wasn't even at the crime scene. Just half his life gone. So we can't allow that with Lucy, and the only way to deal with it is to bring it into the public forefront, which we've done very well with so far. 4 newspapers have called for this case to be referred to the Court of Appeal, but it needs to be intensified further still. So that's why I wrote a book. It wasn't why I started this YouTube channel. That was a pure accident. It wasn't planned, but hopefully people can see the quality of my work now and can see that my book is going to be good. I try not to praise myself, but I do have faith in my ability, and I think people are going to really enjoy it. But I just wanted to highlight this case and make it clear that we have to do everything to avoid this kind of scenario. And the best thing we can do is raise public awareness of this case, because all the science and all the evidence is on Lucy's side. Now we have to ramp everything up so the Court of Appeal knows this isn't just going to be quietly turned away in the background. This is something that the eyes of the national media are on and the eyes of the nation are on. And that's our next task, and it's a critical task. And that's why I wanted to just raise this at the end of this video. I know it's a long video. Hopefully people will see this. I didn't want to do a standalone video. I just wanted to address this while it's topical and just kind of reassure people this is not an indication of what's going to happen in Lucy's case, but it is a warning. It is something that we can learn from, and it's something that we need to be aware of going forward. So that's all I have to say in this video. If you have any comments, questions, queries, all likes, subscriptions, etc. are gratefully received. I really, really, really appreciate your support, and I hope you found this video informative.